There we go. So we missed a little bit, but that's okay, just intros. So
Okay,
I'm gonna
stuff.
pass it over to Corey now.
I'll take it away. Um, I thank you, Sarah. My name is Serena Eagland. As Sarah said, it's nice to be in the Zoom room with you all today. I'm joining you from the Coast Salish Territories, colonially known as Vancouver, where I have worked as a registered nurse in substance use settings for the last 11 years. My clinical experience has been focused on substance use in the context of outreach, primary care, IOT, and I'm currently a clinical nurse specialist for Providence Healthcare, where I focus on substance use initiatives like overdose prevention and response. In terms of my education, I have a bachelor's degree from TRU and a master's in nursing from the University of Calgary. But I do want to just take a moment to say the majority of my knowledge and expertise in substance use has been gained from over a decade working in Vancouver City Centre and in the downtown east side, and learning from people who use drugs and people who provide care for folks who use drugs. So I just want to thank my community for sharing experiences and knowledge with me along the way and every day.
And thank you, Sarah, for getting us started, and thank you, Serena, for joining us for this important conversation today. As Sarah said, my name's Corey. I'm joining from unceded Cowichan Tribe territory today, and I am the president of the Harm Reduction Nurses Association. I've worked in harm reduction for the last 11 years. I've also worked in acute care settings, perioperative care settings. I was an operating room nurse. And I too bring a mix of experience of working alongside people who use drugs, working in supervised consumption services settings, supporting the scale up of naloxone programming, as well as most recently working with AVI Health and Community Services to scale up access to prescribed alternatives as a response to the toxic drug poisoning emergency. I've worked in both Alberta and British Columbia, and I feel like this is a really important issue. And so I'm so grateful for the folks that were able to join today. And if you're watching this recording later, I hope that this proves to be an informative and helpful webinar. Now, I want to get us started off with the best of intentions. This is a divisive and emotionally charged discussion. We will be talking about exposure events, drug poisoning, substance use disorders, and stigma. Please know you can step away at any time, turn down the volume, or leave if that's what feels safe to you. The decision to enter the discourse on topics like illicit drug exposure, misinformation, or involuntary care, or police violence is not taken lightly. We're a volunteer board at the Harm Reduction Nurses Association. We don't seek out government grants. None of us stand to benefit from today's presentation. And in fact, every position we take is met with some degree of opposition. It is not popular to relentlessly challenge misinformation and disinformation, nor is it efficient, nor is it without risk. But we have clinical expertise. We have privilege and a platform. The HRNA is a special interest member with the Canadian Nurses Association. There's an expectation, a moral impetus that we have difficult conversations, dispel misinformation, and above all else, ensure that policy making is driven by ethics, evidence, and the expert opinion of both nurses and people with lived and living experience. If you're watching this today and you're thinking, what Corey and Serena are saying does not match my experience, please know we're not here to dismiss or minimize. Our role here is to share evidence, discuss the implications of reactive and regressive policy, share our association's position on the matter, and offer recommendations that can promote safety for both nurses and people who use drugs. This is not an either-or scenario. Everyone's safety is important. Everyone deserves accurate information about risk. We can do both. It's not a case of nurses versus drug users, nor harm reduction versus treatment, nor nurses versus other nurses. If you want to engage in black and white thinking, you'll have to find another webinar. The ongoing attack on harm reduction has been largely driven by false dichotomies, which is, you either accept the status quo or you implement punitive policies. And so if you oppose punitive policies, you're accused of advocating for the status quo. So let me be clear, nobody wants this. Nobody wants nurses walking through smoke in hospital hallways, not from fentanyl, not from tobacco. Nobody wants that. And so I encourage attendees and viewers later to try to imagine a third, fourth, fifth, or even 100th different option. Resist the false dichotomy presented to you. Lastly, I want to acknowledge the distress many are feeling right now. Our healthcare system is in dire condition. Nurses and other healthcare providers are working short-staffed. Unsafe nurse-to-patient ratios, lack of casual staff pools, mandated overtime, and a spillover of complex and unaddressed social problems are making the situation untenable. These are demonstrable truths, sources of distress, and representative of massive system failure. Under-resourcing, inadequate social programming, and a failure to respond to the colliding housing and poison drug supply emergencies. At no point does criminalizing people who use drugs do anything to address those issues. Let's reset our sights on root causes and government inaction.
So we all know what we've signed up for today. We are going to spend about 45 minutes on our presentation, give or take, and then have some time for questions at the end. So in the interim, we will review BC's ongoing public health emergency, emerging trends within this emergency, and policy implementation failures that have contributed and continue to contribute, the role of misinformation, disinformation, moral panic, and power on this emergency, the available evidence around passive exposure to illicit drugs. Our HRNA position statement on exposure is released today, so we'll have some time to review that, and we'll wrap up by discussing ways to combat moral panic. To set the stage for why we're here today, it's important that we look at the context of the drug supply and drug poisoning deaths over the last nearly 9 years. On April 14th, 2016, then Provincial Health Officer Perry Kendall declared an overdose public health emergency. At the time, there were 997 drug poisoning deaths in BC. In the original public health order, this emergency was summarized by 2 key points, the first of which was in the province of British Columbia, the availability of highly toxic, illegally produced opioid fentanyl analogs is apparently increasing. The second point, as a result, there are increases in people overdosing and in mortalities associated with the use of these substances, alone or with other drugs. So at the time of the declaration of the emergency, we already knew that the unregulated drug supply was causing an unprecedented number of deaths, despite having a clear and a tangible solution to regulate the drug supply. A lack of political will to do so, along with heaps of misinformation, disinformation, and systemic violence has meant that we now have well over 16,000 deaths in the province. We can go next slide, Corey. This graph is from the BC Coroner Service and shows which substances were present in drug poisoning deaths in the province. So as you can see, fentanyl is present in 77% of all deaths. This is a staggering number, and though I look at it regularly in the course of my work, I still find it incredibly distressing to review this information. Looking at this, it really validates a fear of fentanyl exposure. It's real, it's valid, it makes sense that people will be concerned when they walk through fentanyl smoke, because the presence is so prolific in the drug supply and because the information we're given is not accurate. It's important to step back and think about how we're being exposed and what this actually means. So for me, walking through a plume of fentanyl smoke in the street is not scary because of passive exposure. It's scary because it represents the intersection of an unaddressed housing crisis, an income crisis, a lack of access to healthcare, including overdose prevention sites and substance use services, and a drug supply that continues to kill my community members. And not to harp on this slide, but as we talk about fentanyl as a substance and exposure to fentanyl, it's also very important to understand that the other adulterants in the drug supply are out of control. So I'm looking at this graph and like bromazepam, fluorofentanyl, things like medetomidine are not even medications I was aware of as a community nurse 5 years ago. Now they're in the drugs that people are taking at the sites I work at every single day. We can see now in a different visual in the next slide, when we fixate on one piece of the puzzle, that blue line across the top that represents fentanyl, we lose the forest for the trees. So for example, you can see back in 2018, benzos were hardly even on this graph, and now they're detected in half of all deaths. So when we're thinking about the context that we're living in and that we're working in, we're thinking about so much more than just unintended use of fentanyl. We're also thinking about the implications of a drug supply where a drug like fentanyl is mixed with a benzo, which results in long periods of sedation where people have lapses in memory and they're put in very vulnerable positions when they're using outside of an overdose prevention site. This is not just a fentanyl crisis as media would have us believe. This is a crisis of a toxic and unregulated drug supply. And this is also not a crisis that is impacting just areas like the downtown east side. The BC Coroner Service Death Review in 2023 stated, it is estimated that as many as 225,000 people in British Columbia remain at risk of unregulated drug injury or death. There's one last consideration about, then we can go next slide, sorry, Corey, about the public health emergency to think about while we're discussing what else is contributing to this fear. And that's a significant increase in smoking in the last several years and the lack of available services to support this shift. In BC, inhalation or smoking, it's the most common route of consumption. And so as a result, the route that was used in most drug poisoning deaths and continues to be. Some qualitative studies show that a number of people shifted from injecting to smoking drugs starting in 2017, which is, I think, is around when we all saw that happening too, in part due to healthcare education campaigns about smoking having a lower risk of overdose and lower risk of things like soft tissue injuries. So while these education campaigns were effective and community members got word out and supported each other to make that shift, as we'll talk about today, there are very few services available that support people who smoke their drugs, leaving people no choice but to use in ways that increase risk of passive exposure to other people. I'll pass to you, Corey.
Thanks, Serena. I think this is really important information that you just shared, looking at drivers of the drug poisoning emergency, looking at the way the drug poisoning emergency is framed, looking at some of the trends that we know that are available. And so I'll just kind of dovetail what you've said here and say, the realities of the drug supply are well known. Everything Serena just said to you is publicly accessible data. We don't have a secret bank of resources. It's public. That means these trends, the emergence and now dominance of benzodiazepines in the unregulated drug supply, the change in preferred route of consumption from injecting to smoking, none of that is new or unknown to policymakers. These changes in the drug supply should have prompted changes in policy direction, changes in implementation. Many consumption sites, as Serena alluded to, does not allow for inhalation. In fact, most services in BC that work with people who use drugs are completely unprepared for the realities of benzodope and inhalation. In a 2024 report on the implementation of harm reduction programs in BC, the Office of the Auditor General noted deficiencies in the province-wide implementation of overdose prevention and supervised consumption services. It was noted operational guidance lacked minimum service standards and did not always reflect engagement with health authorities, people with lived and living experience, and Indigenous people, leading to the observation that provincial guidance for health authorities and service providers was inadequate, and the guidance was out of step with changes in the toxic drug supply. So what we've seen here is a failure of policy implementation, but we aren't seeing accountability or action on addressing that policy failure. Some, however, see an opportunity. Last year, right around this exact time, actually, an attack on harm reduction took on a new form. What started with a leaked memo from July 2023 garnered significant traction in both traditional and social media. The dominant narrative now was that people who used drugs and the policies and the woke allies that supposedly enabled them were putting nurses at risk for harm. A litany of stories, sometimes the same story told multiple times, were amplified, shared, and for a while, the moral panic producers had successfully created the illusion of vox populi, or the belief that everyone was talking about this and everyone shared the same belief about it. It feels prudent right now just to also say that the folks that were sounding the alarm, the now non-existent BC United, did not care about nurses' health. This was a story, a political wedge tool, an opportunity. I don't remember a single one of them coming to the defense of nurses when we were begging for personal protective equipment in a global pandemic. It's not about our health and safety. It's about power and their willingness to weaponize a distressing situation to attain and retain power. In the absence of accountability and transparency, policy fails. And in the absence of good policy communication, those seizing the opportunity blamed BC's decriminalization pilot. Stories of people smoking crack in a Tim Hortons or nurses walking through smoke in a hallway in a hospital, they were attributed to decriminalization and more broadly harm reduction. And all of this happened in the backdrop of a looming provincial election. And this was successful. It was a successful campaign. It was successful in leading to policy change, and it was nearly successful in leading to a change in government. We must understand and name the cascade of disinformation, misinformation, and moral panic as often as possible. People create disinformation. It does not simply appear. While misinformation is unintentional, like that time that I thought Jeff Goldblum had died and I texted my friend to tell them, and then I found out that it was a fake story. That was misinformation. That was unintentional. I didn't stand anything to gain from that. And people who spread misinformation rarely do have something to gain from it, nor do they generally do it on purpose. Disinformation, on the other hand, must be created, it must be amplified, and it must be believed. And the manufacturers of disinformation do have something to gain from it. Whether it's likes or retweets, subscribers, money, or votes, you have to ask yourself who benefits. And so there's also a common trend in disinformation where the aim is to discredit or sow distrust, and so to undermine evidence, to undermine trusted institutions. And when the cascade of disinformation and misinformation is successful in creating enough of an emotional attachment to the population, a moral panic is possible. I've been studying moral panics now for the last 2 years. I wanted to focus on it because I've gone through a learning curve in my adult life. I'm interested in what drives policy. Early in my nursing career, I believed very naively that policies were developed to address problems and were guided by the best available evidence. What I witnessed as a street nurse was the downstream harms of policies that were not, in fact, guided by evidence and were created by people who did not understand the realities of the problem. Thus, I started reading and learning about policy communication, framing, language, and problem identification. I believed a better understanding of the problem could lead to better solutions. I used Carol Backey's "What's the Problem Represented to Be" approach to break down policies and identify problematizations. But now where I've landed is that we need to stop giving people in power the benefit of the doubt. They know everything I just said and more. They know and have access to the evidence, all the databases, all the research and experts and researchers. They know how to frame and reframe problems, and they certainly understand how to do a root cause analysis. We can manage up all we want, and yet we will not make change unless we talk about power, profits, and panic. And folks, I'm not looking into some crystal ball, and I'm certainly not coining some original theory. Stanley Cohen's moral panic model is from 1972. And moral panic as it pertains to fentanyl in particular is a known concept. This article from Leo Beletsky and other rad humans like toxicologist Ryan Marino wrote about fentanyl panic in 2020, and they appear to have made some chilly predictions. According to Beletsky, fentanyl panic has real-world consequences. Misinformation can also engender counterproductive policies, including hyper-punitive responses, unnecessary expenditures, and pharmaceutical overregulation. Panic also spurs counterproductive policies, including proposals to restrict medical fentanyl access. Concerns about supposed occupational risks of fentanyl exposure to police have been especially persuasive in invigorating hyper-punitive laws, including drug-induced homicide and capital punishment for distributing this supposed weapon of mass destruction. Given the fraught history of US federal government messaging and policymaking in the wake of 9/11, the invocation of this trope is especially telling. This is really a salient quote for 2025, and I'll talk about that a little bit more shortly. In preparation for today's webinar, I completed a short power mapping exercise over the issue of illicit drug exposure. This visual helps to understand and analyze power dynamics. It shows us who's most impacted, who has the influence and power to make change, and where we may find allies in this work. There's only a few examples I'll highlight today due to time constraints. The first is the ongoing exclusion of those most affected by policy. People who use drugs, communities of people disproportionately impacted by drug poisonings, First Nations communities, women and gender expansive populations, Black people and other people of color, they have the most to lose from reactive and regressive policymaking. And yet decision-making around hospital policy, decriminalization, the removal of harm reduction kiosks in hospitals are not informed by those voices. Rather, drug policy remains heavily informed by police, media, and moral entrepreneurs. The ability for law enforcement to issue a statement, hold up a baggie of white powder and say there's enough fentanyl in here to kill 1 million people, and for those stories to run unchallenged, well, that makes this fight against moral panic an uphill battle. Lastly, I would also note labor unions, regulatory colleges play a critical role in striking a balance, resisting reactivity, and both seeking and generating evidence. While these groups do not have as much power as a provincial government, they represent the voices of their members, their strength and solidarity, and they have a unique opportunity to say, yes, I agree this is a problem, and here's how we can make sure everyone can be safe. The question of whether secondary exposure to illicit drugs is safe has received widespread attention in BC. These stories and subsequent media attention led to the BC government to frame this problem as one of public safety, and subsequently to abandon their decriminalization pilot to recriminalize drug possession in public spaces, including hospitals. Notably, decriminalization and exposure are two different problems, and while exposure was the purported issue, the BC government rescinded decriminalization. It's also important to note that this moral panic led to actual reactive hospital policy. And some of the quotes from this, again, publicly accessible policy include self-management of illicit drugs in hospitals or hospital sites is prohibited outside of designated overdose prevention service sites, which is important to note because most hospitals do not have designated overdose prevention service sites. An additional quote from the policy includes non-compliance will be addressed by hospital, relational, and other on-site security in consultation with the patient's clinical team through an escalated process that could ultimately include the discharge of the patient and or police involvement. And all breaches will be documented in the patient safety and learning system and inform the development of further actions. And so these are different iterations and manifestations of criminalization. And criminalization does not stop drug use. We have decades of evidence to show that criminalization does not reduce the amount of people who are using drugs. But what it does do is it drives drug supply volatility. It promotes covert and isolated use, increasing risk for dying alone by drug poisoning. It severs connections to health and social services. Drug seizures increase risk for drug poisonings. All of this is an escalation of harm, a policy not rooted in evidence, and in response to a panic. The Canadian Nurses Association and the Harm Reduction Nurses Association teamed up last year to write an open letter to federal ministers, and an excerpt from this that I think is particularly relevant is that nursing and patient safety is paramount, and the unintentional exposure to substances such as fentanyl must be prevented. However, prohibition-based policies in hospitals, such as promoting security involvement, requiring nurses to search people's personal belongings, disallowing consumption of substances in safe, controlled environments, and using abstinence-based contracts that include paternalistic disciplinary measures do not meaningfully address safety concerns, nor do they prevent unintentional exposures. In fact, invasive and dehumanizing policies such as searching personal belongings have been shown to worsen health outcomes and create new safety concerns for nurses and patients by leading to early discharge, police interactions, and incarceration. Why else does this matter before I hand it back over to Serena? Well, this is timely, and the words of Beletsky and Associates when they were talking about the use of weapons of mass destruction language back in 2020 seems like they knew something that many of us didn't. Canada's sovereignty is facing an existential threat over disproven allegations that illicit fentanyl originating from Canada is significantly contributing to drug poisoning deaths in the United States of America. To appease the White House, the government of Canada appointed a fentanyl czar and invested $1.3 billion to enhance security at the border. The allegations leveled against Canada are severe, resulting in threats of economic ruin and annexation. These accusations are in bad faith, easily disproven, and paints Canada as a negligent actor on the international stage. And it is demonstrable that Canada's contribution to the American illicit fentanyl supply represents a parsley 0.2% of the amount seized at the US land border. So like I said, Beletsky and company were correct in their predictions. And some US lawmakers are now calling for fentanyl to be listed as a weapon of mass destruction. And so we have to pay attention to all of these things because these stories start with this image on the screen. They start with an unchallenged news story. They start with someone saying these two officers touched fentanyl and they started to feel symptoms, and so we're calling it an overdose. These stories that come out, particularly from the United States, is what leads to people thinking that if someone is using fentanyl, that we need to have a bubble around them because going anywhere near them is going to cause harm. This worsens isolation, it creates harms, and it doesn't actually address the problem that we are purporting to try to address. Over to you, Serena.
You. As we get into talking about exposures, it's important to understand why people use drugs at all while they're admitted to the hospital or in a healthcare setting. And it's not because individuals are oppositional or behaviorally challenging or because substance use is a moral failing. In BC, policy changes and our toxic drug supply have made it so that using substances while admitted into the hospital is a non-negotiable for some people if they want to be able to stay in the hospital for the duration of their care and receive treatment for whatever medical issue they're in for. As we saw at the start of this presentation, the supply of drugs here is so volatile that tolerance for opioids has skyrocketed. And as such, we don't have tools within the healthcare system to manage acute pain for some people who use opioids. So they need to continue to use the unregulated supply to have their pain and their withdrawal needs met. This is a failing of our system. Healthcare is not a system that moves nimbly to address issues as they come up. And manufacturing larger doses of opioids to meet people's needs is not something that comes without significant regulatory changes. Even the hospitals who have teams of addictions medicine clinicians who do prescribe larger doses just don't have the tools. It's not that individual healthcare providers don't want to be able to support people's withdrawal and their pain. It's that we can't in a lot of cases. On top of this, people continue to use drugs for reasons that are unrelated but timeless. Boredom, being admitted to the hospital, loneliness, shame, and a history of healthcare trauma that makes people reticent to advocate for themselves and share when they're in withdrawal, when they need some medications for that. And one other complicating factor is if we didn't have enough, substances for personal use were decriminalized in 2023, and then last year they were rolled back, making possession of substances illegal in healthcare, as we just reviewed. So this is how it was previous to the decriminalization pilot. And during those several decades, people still had substances in their pockets and were using drugs in healthcare settings. But now with so much media attention on the newest change, on the recriminalization, on all the stories we've just talked about, there are a lot of questions and situations where people are being punished for using drugs in a way that wasn't happening even just in 2022 before decriminalization, because as it comes up in practice now, nurses and other healthcare workers don't know what to do with that because they haven't been given the information and the tools for how to support people. And we can go next slide. So what do we actually know about secondhand exposure to fentanyl? And I think that's why a lot of you signed up for this today. So as we go into reviewing the evidence, I want to echo what Corey said at the start. Even with more and more evidence showing little risk from secondhand exposure, we are not advocating for nurses and for other healthcare workers to be exposed in the course of their work. It can be scary, it's uncomfortable, it's not what we're signing up for. As someone who doesn't smoke, I don't love it either when I walk into a space and there's smoke present, regardless of the substance. What we do want to do today is talk about the actual risk that comes from these exposures so that you have the information that you need when these situations come up in practice. So first things first, there has never been a confirmed overdose in British Columbia from touching fentanyl, despite those widespread media reports. As with any unknown substance, the health recommendation, if you come into contact with what you think may be fentanyl, is to avoid touching your eyes, nose, mouth, avoid mucous membranes, and wash your hands with soap and water. Second point here, the risk of harm from inhaling secondhand fentanyl is very, very low. This one can be hard to wrap our heads around given this moral panic that Corey's just reviewed, and because we have a lot of evidence about secondhand smoke from cigarettes being quite harmful, and even some about cannabis. What's different with fentanyl is that fentanyl is heated and the individual inhales vapor, which is quite different from smoke. So the low pressure nature of vapor makes exposure quite unlikely. There's more and more evidence coming out now that supports this. There was also a systematic review of occupational exposure to fentanyl done in 2023 that concluded that passive exposure or secondhand smoke does not result in opioid-related symptoms. This is also supported by Washington State Department of Health and by a study done on transit by the Washington School of Public Health. According to American Colleges of Medical Toxicology and Clinical Toxicology, the primary concern with fentanyl, like so many things, is around aerosolization, so namely when it's manufactured into a puffer. That's really important to know because many workplace policies are created in an abundance of caution, which they absolutely should be to protect workers. But because we don't have all the information, these policies are not specific to the actual worksite and practices and don't completely align. So does it make sense for us to be approaching exposures as if that's fentanyl is aerosolized versus how we're actually seeing in practice? In instances where people did file workplace health reports, symptoms that are often reported are sweating, lightheadedness, racing heart, sometimes dizziness. These symptoms are not consistent with an opioid overdose and are more likely caused by other very valid health conditions being triggered, such as anxiety. Again, this is a valid response to a situation that has been clouded with such misinformation. We can go to the next slide to chat about thresholds. It's very science. In 2024, the American Conference of Government Industrial Hygienists published threshold limits for fentanyl for occupational exposure, which WorkSafe BC has now approved for use in BC. These are guidelines that outline acceptable exposure limits to different substances, in this case fentanyl, in workplaces to provide guidance on safe versus unsafe working conditions around particular substances. And if we go to the next slide, we have some precedent for how we can do this safely. Corey, may you flip us? Some of you on the call may be aware of this, but about a year ago, the St. Paul's Overdose Prevention Site expanded to include inhalation in the model, so people who are admitted to the hospital can access the site to inhale substances. And when the overdose prevention site expanded, peer support workers working in that inhalation space and in the injection space wore monitors over 2 shifts for a total of 16 hours. And exposures fell well within acceptable limits based on that last slide, which helps to set a precedent that it is very possible to provide safer inhalation spaces in healthcare settings without putting workers at risk. So what does all of it actually mean? It's twofold. Healthcare providers need to be receiving more information and evidence on actual risk with policies that support their work. It also means from all of the research, we can now say pretty confidently that there is very little imminent risk to staff who walk into a space where substances have been smoked. That is not to say that workplaces should not provide environmental controls and PPE. They absolutely should. They should also be sharing information on what they're actually providing protection against and what the real risk is. So we are pleased on the next slide to announce that our position statement on illicit drug exposure is live on the website as of today and reads, the Harm Reduction Nurses Association firmly opposes punitive and reactive policymaking that penalizes patients for illicit drug use in hospitals. While we acknowledge healthcare workers' fears related to illicit drug exposure, we highlight the lack of available resources and accurate information regarding their safety and safety of their patients. We believe that policies prohibiting illicit drug use in healthcare settings also fail to protect people who use drugs and ultimately compromise their health, well-being, and access to life-saving healthcare. In Canada, all people have the right to access healthcare and should not be persecuted for substance use by healthcare providers. We urge decision makers to respond with pragmatic and evidence-informed information and solutions that respect both patient and healthcare worker safety. More specifically, we call for the dissemination of accurate information on drug exposure risks and rapid implementation of overdose prevention sites in health services such as hospitals and re-implementation of harm reduction vending machines at hospitals in the province. With our position statement, we also have some evidence-informed recommendations. The first being the implementation of overdose prevention sites that support both inhalation and injection of substances in or adjacent to hospitals. Overdose prevention sites are not a new intervention. Legally, they have been around since the early 2000s in BC. They've been around for longer with folks supporting each other to use safely before that. So at this point, we can confidently say that implementation of overdose prevention sites reduces the risk of unwitnessed overdoses, supports patients to manage withdrawal and pain while admitted that our system does not have the tools to do so that they can stay in the hospital for the duration of medical care. Overdose prevention sites also reduce safety risks through environmental and relational controls, decrease over-surveillance of an already over-criminalized and over-surveilled population, and promote a harm reduction approach that prioritizes the well-being and health of people who use drugs. Part 2 of the recommendations are to continue to promote the safety of both people who use drugs and of staff by having policies and practices that are patient-centered rather than punitive. such as providing sterile equipment for substance use and providing staff with training on how to support patients to use this equipment in order to reduce the risk of using particular substances. This is also an evidence-based approach that has worked for decades. The recommendations to support staff and patient safety recognize that having dedicated spaces for people to inhale substances decreases the need for people to use at their bedside or in common areas or in bathrooms, thereby decreasing instances of passive exposure to staff and other patients. Having these services and these policies that promote the well-being of people who use drugs rather than policies that punish people for doing so means we avoid the situation where healthcare workers are de facto enforcers of public safety, trying to wade through policies and misinformation that suggests we should be doing things like confiscating substances and intervening in substance use because that makes our workspaces safer for us. We know that these approaches are incredibly harmful, and this is what leads to moral distress and moral injury for healthcare workers. I'll pass back to you, Corey.
All right, and just to wrap up here now and have time for questions. This position statement is part of a bigger movement that we all need to participate in. Serena, Patty Wilson, who's been another author, who's another nurse who's been working with Serena and myself on some of our publications in Healthy Debate and Canadian Nurse. We can, continue to issue statements, to write articles, but we need everybody to lean into the goal of targeting disinformation and misinformation at the source. And one of the ways that we can do that is to acknowledge the truths that are wrapped around the panic. Like effective disinformation, effective moral panic is often embedded within really observable truths that people can see and they can name. And so, what's happening on our streets is not normal. It's not normal to see people incapacitated for hours on end, poisoned by benzodope and animal tranquilizers. It's not normal to see this many people outside without shelter, without homes, struggling. That creates real distress. We have to acknowledge that distress, right? And we have to know that a lot of the fear and apprehension that people are experiencing are based in very valid observations. And so let's not minimize that. There are some real big issues that are going unaddressed. And if we can acknowledge that, then we can resist false dichotomies. This is not a scenario where the only way to make sure people who use drugs are safe is to compromise the safety of nurses and healthcare providers. This is not a scenario where one person's safety results in lack of safety for another. We can implement strategies, as our position statement and as Serena has alluded to, that ensures everybody is safe. And so if someone says it's either this chaos, or we do that, or we involuntarily treat people, or we kick people out of hospital for using drugs, or we make nurses into security guards, say absolutely not. I reject the premise of that framing. We can do so many more things. We could regulate the drug supply. We could create safer use spaces. We can embed more services and more supports that honors the fact that everybody deserves access to safety and everybody deserves access to healthcare. And you can do that not just braving it on your own. You can do that by joining groups like the Harm Reduction Nurses Association. You can do that by taking this position statement, which is available now publicly on our site, and I'll share the link in the chat as soon as I'm done sharing my screen. You share that position statement with others. Welcome difficult conversations, acknowledge the truths and the discomforts, and just know that there's strength in numbers. We don't have to do it all on our lonesome. And lastly, as I've said, let's stop giving people in power the benefit of the doubt. Let's acknowledge the role that power plays in policymaking. Let's acknowledge that policymaking is often being driven by factors that are not about evidence and ethics. And if we do that, then we can really hold our governments and our decision makers to account. We can actually ask them questions like, how does this hospital policy stop the deaths? How does recriminalizing people get everybody housed? Go back to the root cause and really make people be accountable for the policy decisions that they're making. And so I'm thankful for your time. I'm so thankful that Serena was able to join and participate. And I'm really grateful for Sarah Lovegrove for moderating. We've got time for questions now. So my thanks goes to you. I'll just show off these reference pages as well so that people know that we did our homework. And of course, yes, those we'll make the reference list available on request, and we'll share this webinar. The intent is for it to go on our YouTube page.
All right. Thank you both so much. That was incredible amount of information and knowledge, and yeah, enlightening for a lot of folks who I'm sure have been struggling in hospitals and facing these challenges. So thank you both so much. So I just
You
encourage
want
folks.
to turn record off?
Oh yeah, let's do that.